Welcome to Health IT Matters, a podcast in which we explore the ways health information technology is transforming healthcare locally in Florida and on a national level. Health IT Matters will be held on the third Thursday of each month and will explore the many facets of the ever-growing health IT spectrum. I'm your host, Corinne Slaughterback. Kicking off the beginning of this series of Health IT Matters, Kim Davis-Allen speaks with Dylan Dunlap, the program coordinator for the Medicaid Promoting Interoperability program at the Agency for Healthcare Administration. Dylan and Kim discuss what to expect for the Promoting Interoperability program year 2021.
Welcome again, everyone. I am Kim Davis-Allen, and yes, we are doing something a little bit different today. We have the webcams going. And we're, even the approach and the content of our webinar is a little bit different today. We're just going to kind of have a fireside chat, as we like to call it, with Dylan Dunlap. Dylan, you want to say hello?
Hey, everybody. It's nice to be with you here, live on camera today. We'll do something a little different.
Let's hope it all goes well. This is our first webinar of 2021, and as always, we appreciate your time of signing on and your attention. Even though we're going to be continuing our webinar series, we want to try to do something a little bit differently and kind of give you kind of a wide breadth of information, kind of a different approach in looking at the program and what's going to happen beyond the program as well. So I do want to start with just a couple of slides, and then I'm just going to kind of have a chat with Dylan. I don't know if you can see, we're going to call these a fireside chat. And we've used this format for other avenues and other ways of communicating, especially with our HIE partners, and it really has seemed to do well. So we want you to be involved. If you're not familiar with our webinar platform, there's two ways to ask questions. You can always raise your hand and we can unmute your line, or you can type your questions into the question box and we'll be taking those along the way as well. So let me start with a slide or two to kind of frame up the conversation. I hope everybody can see okay. So just a couple of key reminders as we start talking about program year 2020. So we're going to talk about the program as a whole, definitely talk about program year 2020, and then really kind of start looking ahead at program year 2021. So for program year 2020, just to remind you that all program requirements have to have been met by December the 31st. So hopefully you got all of that done. You've been running your reports. You've started your application. I think we maybe even paid a few applications, Dylan. You can kind of give us an update on that. And then our application due date for program year 2020 is actually going to be not February the 1st, 2021. But what were you telling me, Dylan?
So it hasn't been completely finalized. We're still waiting for something in writing from CMS, but we did get verbal approval from our CMS lead to back the deadline up a little bit. We had heard from several providers that were still waiting on their clinical quality measure reports, and this spanned across different vendors. So I think that, along with just pandemic related priorities that people are working through, it makes sense to push it back a little bit. I'll kind of go over that in more detail, later in the webinar today, but we'll probably send something out on Monday and go ahead and open our website or update the website to have the new deadline listed, which would be March 1st, which would essentially give providers another 4 weeks.
Okay. Yeah, a lot of people are still struggling with the upsurge in the number of COVID cases and just kind of getting back in the swing of things. So speaking of program year 2020, kind of tell us what's happening. Number of applications, problems, issues. What are y'all seeing with applications?
So we opened the system back in the fall. I think we opened it in mid-September, and it was eerily quiet. I mean, I remember meeting with the processors and saying, man, maybe this is it, between the pandemic and stage 3 and providers finishing the program and no longer able to start the program. Maybe we're just only going to have a handful. So I don't think we had our first submission until December. And then the holidays passed and we did see a notable increase. I think we've got over 100 applications submitted. We've approved about half of those. And I would say at the rate that we're going, we're probably going to get another 100 or so. So as far as the issues, it's stage 3. So a lot of the same issues as that we saw in 2019 when stage 3 really became mandatory for providers that were participating in the program. So what hangs people up are definitely the patient engagement health information exchange objectives. Those are really the meat of the meaningful use stage 3 requirements, and that's what we see providers that aren't able to meet those requirements. The other challenge is the way that the measures work. It can be a little confusing to providers. Sometimes people think they're passing the measure when they're actually failing it, and sometimes people think they're failing it and they're actually passing it. So it's a little confusing the way it works with the exclusions and passing 2 of 3 and things like that. So if you have any questions or you need me or one of our staff members to kind of talk you through it, we'll have our Medicaid HIT inbox email address in a later slide. You can contact us through that email address. We can set up a conference call or work through any issues that you may have. But those are probably the big things, Kim. You know, people just getting used to the stage 3 requirements, and you know, some people are realizing that, you know, it's more challenging than they anticipated. And we've had several people say, you know, that we did stage 1 and 2, but stage 3, you know, just there isn't as much of a return on investment for us, and so, you know, we're not going to move forward. But we've also had some groups that have stuck with it and, you know, didn't meet the measures last year but are meeting them this year. So I think everybody's kind of in a different situation.
Okay. And so one of the things that I really just want to, and you'll hear me say this a lot, is I do encourage you to reach out. You know, don't think you have to wait till your application is submitted. If you have a question, or hopefully you're doing your application is correct, because the processors, they're an amazing team, and they're willing to work with you along the way. And there's a little bit of downtime, as we've seen with applications in the past. The closer that deadline gets, definitely the more applications that will come in, and they won't have as much time. Okay. So speaking of Program Year 2020, we're now actually beginning to look at requirements for Program Year 2021, which is crazy. I've been with this program since its inception back in 2009, 2010, and now we're already at the end of the program. That's been a fast 10 years. So tell us a little bit about Program Year 2021, since it is the end of the program.
So Program Year 2021 is the last year, you know, of meaningful use, and it's going to be a challenging year for more than one reason. The first thing is the High-Tech Act, which is where a lot of this funding comes from, ends at the end of this year on December 31st. And I don't know when the legislation was written if they really knew how states would be making these payments and things like that. But this kind of emerged in the last few years, where states started looking at the end date going, how are we going to make payments if all the payments have to be made by the end of Program Year 2021 or calendar year 2021? So I think CMS kind of realized this. They looked at the legislation and then realized, you know, that it just couldn't be changed for one reason or another. So they basically told states, we're going to allow providers to have 90-day reporting periods for clinical quality measures and meaningful use measures for 2020 and 2021. But it still kind of creates a year to where we're approving Program Year 2020 and 2021 within 1 year. And in a state like in Florida, where we have a lot of providers, that's extremely difficult to do. You know, typically it takes us a year really from start to finish by the time we install the system, have our application submission deadline, and then have the review period where we're moving those applications to an approvable status. So we're having to do that in about half the time. So you're going to have much more aggressive deadlines. And I think what will really be different from the perspective of the people applying is that you're going to really submit your Program Year 2020, and usually you get to a point where, okay, it's approved, I can take a deep breath and maybe pick something else up for a while. It's almost going to turn right to 2021, because our deadline to submit a 2021 application is probably going to be in the middle of the summer, late July, early August. So that's really going to limit providers, because so many people are used to really using the end of the year as their reporting period, that it's going to be different for people to submit an application and then turn right around and look at like a reporting period in the first part of 2021. I think that's going to be different, and I think there's people that have already communicated to us that they may not even return for 2021 because of that. But I thought just giving you the background of why it's like that would be helpful. It's really something that we don't control at the state level. We've kind of got to work with the legislation. And I think we have a good plan in place, and it will go as smoothly as it can. But, you know, I feel like every year we get to a certain situation where most of our providers have been paid, and we're working with like a handful of providers, and a lot of those we can get them to an approvable state. But I think this year I really am concerned about there being some applications that really probably would be approvable if a few things, you know, were fixed with the application and documents uploaded that we needed. I'm worried that some of those might not get approved in time. So that's going to be, you know, the risk from providers applying. You know, it's really the good news is that we're caught up from a processing standpoint, meaning that when you submit your application, you should hear back from us within a few weeks. I think the processors are pretty caught up. They're looking at things within about 2 weeks right now. That will probably increase a little bit as we get closer to the deadline. But the key for people that are submitting applications is to stay engaged, be responsive when a processor reaches out to you. We know you have, you know, other things that you have to take care of as well, but because of the way the deadlines are this year, it's going to be really important to prioritize your EHR incentive program applications if you can.
So I heard you say, and I know you don't have all of the dates down about summertime open and closing for 2021. So that is going to be a very short period of time to get these 2020s wrapped up with the extension of the deadline.
Right, right. So, you know, we're thinking we'll be looking at approving program year 2020 applications probably through the end of April, early May. And then we'll install the new version of the MAPR application system, which has the updated requirements for clinical quality measures and things like that for 2021. Then we'll open the system. Providers will have at least 60 days, you know, to get in and submit their application. And then, you know, we'll see how many applications get submitted. We're definitely going to try to be as flexible as we can. But, you know, in order to get all the payments due by the end of the year, we're looking at having to have the approve button pushed on these applications in late October, early November, which is just a really quick turnaround because most people don't even really start thinking about meaningful use until later in the year.
That's right, that last quarter. That's what we see the majority of our applications coming in. All right, so definitely be as soon as those dates are finalized, and I just have to give a shout out to Dylan. There's a lot of complicated legislation around this last year, so just figuring that out and getting that CMS approval is really key. So thank you, Dylan, for doing that as early as you've done that. So that'll help everybody. So one of the things I meant to say is that this is the end of the last year of the program, and you did mention the number of returning providers. So far, we have paid 555 year 6 providers, which is really tremendous, especially when we look at Florida compared to other states. That means that providers have stuck with the program for the entire 6 years of payment. So that's pretty good, and I think once we get 2020 applications, that number will definitely increase as well. So that's good. And we are getting a few questions in, so I'm going to come back to those in just a minute. So Dylan, the other question that I get a lot is, so if the program ends this year, what about audits? Do audits also end this year? Are there still going to be audits? What does that look like?
So Florida is actually more caught up than some states. You know, we do a lot of prepayment, so it takes longer on the front end, but it goes a little easier in post-payment. So the auditors are in their audit round now. That's going well. There probably will be another full round and then a partial round. So we expect to be done with our audits at the end of next year, so 2022. Now, I have to mention one thing, even though the state will have fulfilled our audit obligation, you know, to what we told CMS that we would do, providers are still required to maintain their documentation for 6 years after the payment's made. And why that's important is I think it's very unlikely, but you know, someone from the state level or the federal level, you know, an attorney general or the federal government could potentially come in and say, hey, we want to look at your meaningful use documentation. Probably not likely, but just make sure that you're saving this documentation and keeping it at least 6 years from the time the payment was made, even after we complete our audit rounds. But I think the state's auditing will be done at the end of 2022. So I know there's a lot of, you know, contacts that are still working through audits. Just know that the light's kind of at the end of the tunnel with that. Just kind of hang in there. KPMG has said, which is our vendor that does all of our post-payment auditing, has said great things about the group of auditees that we have this year. So everybody's, kind of has maybe been audited before and it goes a little bit smoother. But that's a good question, Kim. I think that we'll be done here the end of next year, but we all need to make sure that we're maintaining our documentation, for 6 years from the time that we get that payment.
That is definitely a good reminder, because even though we haven't heard a lot of details from the feds, that is always going to be a requirement for any kind of federal payment program, is that 6 years. So Dylan, I want to take just a couple of questions, because then I want to shift kind of from program specifics to kind of more lessons learned. All right, I'm just going to read some of these out since I know you can't see them. With the earlier due dates, will we be able to use the existing security risk assessment, SRA, or will we need to do an interim SRA for the period we report for program year 21? And I know we've developed some FAQs around this.
Yeah, that's a really good question. And CMS did give us some flexibility here. Most of us were used to uploading that SRA whenever we submitted the application. So you bring up a good point. When you look at 2021, if your entity is doing their security risk assessment, typically at the end of the year, when you're submitting the application, it hasn't been done yet. So there is that requirement in the rule that says you can't use the same security risk assessment from a prior program year. So what CMS has done is they've allowed states to have some flexibility with this, and we're going to take advantage of that. So one of the enhancements in MAPR is going to allow you just to acknowledge the requirement. So when you get to the SRA portion, if you've done a review, which if you're in a position to do one, by all means, go ahead and do it and upload the SRA with the application. But if you're a larger entity or you're contracted with someone that does it later in the year, you would be able to check a checkbox that says, I acknowledge the requirement that I have to do a security risk assessment by the end of this year. And that will become a function of the post-payment audit if that provider is selected, and we would not look at it at the prepayment verification stage. So that'll work a little differently. It's still required to be uploaded for 2020, but for 2021, if you were going to do it after you submit your application, MAPR is designed to allow you to do that.
Okay.
And we'll have an FAQ around that kind of puts that in plain language where people understand the requirements. And we'll probably do some emailing at the end of the year. I think we can pull some things from MAPR and say, hey, you selected that you're going to do this later. Just make sure you go ahead and do that and do it by the end of the year and save it in your meaningful use files.
Okay. Yes. Okay. So the other question is more of a vendor-specific question, but because other people may have the same question. So it says, the problem with the shorter 2021 is that Athena always uses the last quarter and validates the data in the measures before they provide an attestation letter. Mm-hmm. What should we do? Should we use the reports they provide in their dashboard to attest? And you may know what the attestation letter is.
Yeah, every vendor's different, and I have heard some folks that said Athena, had some delays this year with getting their reports finalized. They have to know, a lot of what we've talked about today is in federal rule. It's been talked about, at a national level that states are going to have to make payments earlier. Reporting periods are going to end in the middle of program year 2021. So, I think it's just something that you really need to work with them to figure out exactly what their plan is for 2021. The problem at the state level is we don't have any authority over vendors. The oversight for vendors occurs at the federal level through the Office of the National Coordinator for Health IT. So really, other than just referring you, to the ONC as they're known, they do have a process where you can provide feedback, but I don't know what that process entails. I think they, tell you to try to work with your vendor. And then if that doesn't work, I think someone from the ONC tries to help move it along. But I think we're going to see that more from just Athena. I think it's very challenging for vendors. If you think about, we don't really notice it as much, but requirements are still kind of being updated. And it's little things, maybe they change a version of a CQM. Well, a vendor has to process that, make changes in their system, adjust their reports, and do all that stuff. So there is I kind of see the dilemma on the vendor side. I don't think it's all of their fault. But I think just in general, try to work with the vendor, share the information. A lot of vendors will email us and just ask us, hey, what's your reporting period end date going to be? And we tell them. But I think, there is a federal entity out there that we can connect you to if it's a situation like they're telling us that they're not going to have any reports available. Because although I don't know if it's written anywhere in federal rule, if the system's been certified to be a 2015 system, the federal government is basically saying it should be able to do everything, that's required for meaningful use, which in my opinion would mean generating a report that says you're either passing or failing the measures, and it's collecting clinical quality data. So if nothing else, it definitely needs to be reported to the federal government, where they can look at that vendor cert to make sure that it does need to be certified as a 2015 system or not.
Okay. And that kind of goes back to the earlier issue you were talking about with the clinical quality measures and that sort of thing. So if you just be sure that you work with your vendor to know what you can expect so that you don't run up against these deadlines, especially for 2021, and not have the information that you need. Okay. All right. So that was really like all of our programming kind of specific questions. I kind of wanted to shift gears a little bit because Dylan's been with the program about as long as I have in some capacity. So we'll kind of put you on the spot and get your perspective on some things. So, so the first thing, and I think we get this question a lot too, even for our year 6 providers, if they've gotten all 6 years of the program, or for 2021 is the end of the program, what are the agency's plans? What happens now with providers achieving meaningful use?
So there's not anything at the state level that we're aware of at this time, and there's not really a subsequent program that we're aware of at the federal level. I mean, I think that we're going to learn a lot over the next 6 months to a year. There's a new administration now. We really don't know what their priorities and initiatives will be. But also remember that the original EHR program came out of a stimulus package. So when you hear all these stimulus packages being mentioned, there's a possibility that maybe something related to EHRs or health information technology gets picked up in that. We definitely have people at the agency that are keeping an ear out for things like that. I really think at an agency level, we've explored things like mapper reuse. We have this application system. We've had conversations with Medicaid quality, and they're collecting similar data, because of the way that managed care works now. But I think that they're really looking at trying to make it efficient for providers. And when you look at Mapper, it's a great system. It does really what we need it to do for incentive payments, but it's not very user friendly, meaning that you're having to manually input all of your CQM data, all of your meaningful use data. So there really isn't a huge desire at the agency level to maybe reuse or repurpose Mapper for something else. I think the biggest thing for providers to just be aware of is that as the EHR program is kind of winding down, there's a lot of stuff going on with health information exchange, both at the national level and the state level. And I think, Kim, we have some webinars planned in the coming months where we'll have some HIE staff members on to kind of talk about some different things that are out there. But I really think as far as funding that's going to be available that passes through the state from the federal government, I think it's going to be related to health information exchange initiatives, connecting people to different services that the Florida HIE has, things like that. So that's probably where my focus would shift, as a provider or a group that's participated in this program. Maybe where is there another funding opportunity for me? And it wouldn't be necessarily getting incentives to do that, but it would be like maybe making the connection, and then the incentive is really you're able to use that to make your group more efficient or cut your cost or things like that.
One of the things we talked about last year was such an investment. Yeah, it was nice to get the incentive payment, but we recognize the incentive payments probably were not even a drop in the bucket to your overall investment. But now that you have this investment and you've spent so much money on your system, spent so much money on your staff and your resources and your time, really look for those ways to leverage it ongoing. And you're right, I didn't even think about potential legislation coming out of this new administration. I know a lot of value-based payments for insurance companies are based on being able to exchange information. And you're right, we're definitely going to make sure that everyone is aware of the health information exchange opportunities that are out there as well. So what overall do you think are the lessons learned from such a program, incentive program? You know, and you indicated earlier, so this was high-tech funding written 2008, 2009, thinking that, you know, the thing that comes to my mind is that they really thought providers would have this very straight trajectory of stage 1, stage 2, stage 3. That hasn't happened. So what do you think are some of the lessons learned from a program such as this?
Yeah, and that's a tough question, and I'm going to try to be as diplomatic as possible, but I think it's important to be genuine as well. And I think one of the fundamental issues, you know, that we worked through was the way that the eligibility requirements were set up with you have to have 30% Medicaid volume, and we're going to define it by encounter, which providers were not used to that. They speak in procedures, visits, unique patients. So you have this encounter thing, and it confused providers. And we really spent a lot of our time working through volume issues. And I think that took away from really what the program was intending to do, which was maximize meaningful use through electronic health records. And I wish that looking back, I think it would have been better to do, even if you did an initial, like you have to have 30% Medicaid to get in the program and do AIU. I think it would have been more effective had they just grandfathered people in at that point and said, once you've passed that initial Medicaid volume check, if you maintain your Medicaid active, fully enrolled file with the state and you're a licensed provider in Florida, that you can go through the rest of the program. Because we lost a lot of providers along the way too, where they went from like 31% to 29%. And that just seems like at the end of the day, when you're really trying to promote electronic health record systems and the usage of them, that we spend way too much time, you know, looking at eligibility requirements. And I think that was something that probably just wasn't fully understood when the legislation was written. And I think that CMS has learned from that, because from what people tell me, similar programs like the MIPS program, you know, is much more easy for providers to determine if they're eligible for it. It's based on payments, and there's a website that tells you whether you have to participate or not. But I think that that's one of the fundamental flaws of the EHR program. And the other thing that I think really, in hindsight, really stands out, and this, we may have a guest speaker later in the year, and she kind of picked up on this, is we were looking at some trends in Florida's data, and you really get to like 2014, 2015, and it really dropped off a lot. You know, we had a year to where I think we paid 3,500, you know, payments in 1 year. And then it kind of levels off, and as you get into stage 2 and stage 3, it really, you know, took a nosedive. But I think looking back in the beginning of the program, the federal government was paying what they called regional extension centers to sign people up for the program, and they kind of served as consultants, and their fees were paid by the federal government through the state. And those contracts, I think, ended around 2014, 2015. And I think the original thought was, hey, let's get the program off the ground. Let's get people, you know, signed up and familiar with meaningful use. And they really did a good job at that. But I think what we learned, and from what people told me over the years, is like, look, we appreciate there being people at the state level that can explain this, but we really need somebody here that can run this report for us or can tell us how we can improve this measure. And I think looking back on that, that was a missed opportunity. I think that something should have been done to continue those regional extension centers, the funding being offset from them much longer. Some of them still operate, but of course, without federal funding, they're having to charge fees to providers, and most people can't pay them. So that's another big one. And then I would just say, you know, Florida got really lucky, and I can't take credit for this because I started as a program coordinator in 2017. But the previous program coordinator, Mary Schranker, kind of set the program up to be really focused on prepayment verification and less on auditing. And I think it took it a few years for people to realize that that's really the way to do the program, because what states did in the beginning and got themselves into trouble, they had an automated system where the application gets automatically paid and there's no verification and everything's done in post payment. But the problem with that is years later, those states are bogged down in issues where they made payments to people that didn't qualify. And we haven't seen that a lot in Florida. So, I think that was a great job by Mary Schrenker to set the program up that way, and other, leaders at ACA that weighed in at the time, because we've had very few issues with having to take money back, from providers, which is something you want to avoid. It's one thing to tell somebody they don't qualify. It's a lot different to come in and say, hey, we paid you all this money and you don't qualify for it. But those are the big three for me.
And those are really good points. I had forgotten about the regional extension centers, because they really played a pivotal role, especially for those providers who had never even had a system, to help them even understand how to achieve a system. I know our earlier program projections, we'd have around 5,000, give or take, unique providers that participate in the program. That's got at least one payment. And our latest numbers are 9,061. So that definitely a lot more participation, but you're right. A lot of those really early payments, because it was all just about having a system or getting a system, and then as you started having to achieve meaningful use and it got harder, the numbers have significantly dropped off. And I do totally agree about the prepayment. It was always interesting, the states that would come knocking saying, what are you doing? You're not having to do 30 and 40 recoupments a year. What's the difference? And so states have adopted a lot of the prepayment verifications that were put in place by Florida. Those are good 3 points. So what are some of the success stories that you've heard? I mean, you work a lot with providers one-on-one, processors work. So what are some of the success stories from this program?
The ones that stand out to me, and I know we have some processors listening in, and they probably agree with this, was especially when you're working with smaller practices that they don't have dedicated staff to do meaningful use. It's an office manager, or sometimes even the doctor themselves, working through it with them, and it's such a technical, complex program. There's just no way around it. Sometimes it seems a little bit too much and can be overwhelming. But really, the ones that stand out to me are where it was like getting on the phone with providers and they're like, we're never going to be able to meet this. And it's like, look, just stick with it. Maybe try this, or listen, or maybe try this that another person, tried and improved their certain measure and got them to a point where it was approvable. And, we've also had issues where even large entities, we had one that they got AIU, I think they qualified for stage 1. Then they ran into significant issues with the way that their patient portal worked and how their providers communicated with patients through direct messaging. And, they had to basically overhaul their system and didn't get any stage 2 payments, installed a 2015 system, and came back in for the stage 3 final years of the program. So there's a lot of little stories like that in between, but I think providers deserve a lot of credit for really making this program so successful, because they've done the little things on the ground that I think gets missed, whether it's just having a conversation about a patient portal with a patient, or, trying to take time in their free time to understand how they need to utilize their system, or making calls to vendors. I think that's really made health IT kind of advance more than anything, else has. So I think just it's been a pleasure to work with the providers in Florida, hearing their own success, and even times where they don't get payments. Hey, I'm using my system like this, it's easier for me. Those are the things that really stand out to me.
So this is more on a personal side. So do you think have your provider having an electronic health record and patient portal and all of those health IT tools has made you a better patient? Or having access to those tools has made you a better patient?
I think it has, in a way. I like, I'm not one of those people where I want to be in like total control of my health information, but I like to have the oversight of it, to make sure that what's in there is correct. And, I think what you realize is on the patient side of things, there's a lot of tools available to you now that weren't available before. You really were kind of dependent on the doctor, and maybe WebMD to kind of figure out what was really wrong with you sometimes. And I think now when you go in, whether it's a sinus infection or something more serious, there's so much information that you can get to now through patient portals and things like that, whether it's patient education, the way that, you can look at lab results and trends and things like that. that's very interesting, to me as a patient. And, I've gotten more familiar with the way my patient portal works, and there's some functionality that I like within it, like making appointments and refilling prescriptions and things like that. But they're all different, and I think that everybody probably has a different response to that. But I do like the fact that I can kind of see what's on my record, and, just recently, this is funny. I, you know, went to the doctor's office probably like 3 years ago, and my blood pressure was like a little bit high, which they say that that's pretty common when people come to the doctor, is they get the lab coat, high blood pressure, and it hasn't been high since, so I was looking at my patient portal the other day, and I'm like, why in the world does my blood pressure still show the one bad reading I've had in 5 years, And so the last time I went to the doctor, I was like, can you please have somebody update that? Because if I go to have to get life insurance or something like that, they're just going to key in on that. But that's just kind of, you wouldn't have had that opportunity before. And it's probably just someone didn't click a button in the EHR system to pull the most recent one in. But I like having that oversight of it. And I think it helps you when you visit the doctor, you're kind of more prepared to, hey, I noticed this in my lab work that, this seems to be bouncing around all over the place. Before, it was just like, you were kind of relying on the doctor, telling you exactly what to do, and couldn't really weigh in as much.
I'm like you. It took me a while, but I really do like the patient portal. I feel more connected and that I can get an answer. I don't feel so bad about emailing in the middle of the night, just waiting for an answer versus having to sit on the phone or bother a nurse or something like that. And you're right, the information in it can be very valuable and for tracking purposes. So I tell people all the time, we're all patients. At some point, we're all a patient. So really, the information that we have combined from this side of the house really, I think, kind of impacts how we operate as a patient too, or should impact it.
And I think we're all just now kind of getting used to it. You talk about lessons learned. We spent a ton of money on incentive payments and, things like that. But I think we missed an opportunity to really create this awareness of what's changing in the healthcare world with electronic health record systems. And I really think, just creating more of an awareness at a national level of, hey, this is out there, providers are doing it, you're going to hear about patient portals, this is what they can do, and not put that as much on the providers. I think it would have advanced it quicker, because I think a lot of people are just now breaking through of like, oh, this patient portal that my provider's been talking about for years actually is pretty user friendly, and I can do a lot of things with it. There's always going to be people that don't use it. I mean, there's still people that prefer to write checks, and debit cards have been around for 20 years now. But, a majority of the population is seeing the benefit in it. And I think that that's going to continue to be a trend as we move into the future.
You're right. That whole patient education, it kind of had an upsurge and then just kind of went away. So overall, like, the whole thing about electronic health records is setting the foundation for health information exchange, patient engagement, all of that. So how do you think the program has impacted, and you kind of touched on a little bit, just how information is shared as a whole between clinicians, between patients? What do you kind of see in that arena, or what do you think about in that arena? Is it easier? Is it easier to be a patient now? Is it easier to see multiple doctors now?
It seems more efficient, and I know it's more efficient, but I think it kind of gets masked a little bit in that as we create more time for ourselves, like because we're using the EHR system and it's more efficient at certain things, then other things get plugged into it, and that kind of, it offsets that benefit a little bit. And it's important stuff. It's stuff that needs to be done. And an example is prescription drug monitoring. That's a thing that really, when the program started, that wasn't on our radar at all. And so you started using these health IT systems, and that came into where most providers are having to do that now, all of them in Florida, if they prescribe controlled substances. So I think you get more efficient, but other things kind of come on board, and that offsets it a little bit. But I still think at the end of the day, we're much better off than we were 10 years ago. And I think as a patient, when you go into the exam room now, before it was like you were going into a computer lab, people were trying to figure out how to work the computer, what button to click and things like that. And now the computer's in there, but you don't notice it as much. It's almost like an extension of that provider, and they're able to use it to guide them through your visit. And I do think it makes it more efficient and effective, on the patient side. I think another big thing that really needs to be looked at is I think that we need to do a better job at the state and federal level of listening to the providers at this point. We've laid the foundation, and there's no easy way to do that. You just have to put it down, and some stuff's going to work and some stuff's not. But I think we're at the point to where providers can give really good feedback about what works and what doesn't work in these systems, and how, when they only have a few minutes with each patient, how can we really maximize the information that they're looking at? I think there needs to be a forum, nationally, that can get to someone that can actually do some of those things, because I don't think we're going to turn the next corner until they bring the provider into it more and say, okay, what do we need to do to make your job easier? I think the provider, has kind of been left out in that a lot, in the beginning of this, and I think it's time to kind of have more of those conversations.
And I think we've seen that through, as you talked about earlier, some of the challenges providers have encountered, even just meeting the meaningful use requirements. I guess the timeline, the measures, all of that. But you're right. I hope it has also increased awareness of a lot of the other systems that they may or may not otherwise have been aware of. Now, and I don't want anybody to think that we don't recognize there's still a lot of challenges on the provider side. We still hear from providers that the systems are cumbersome. They still just haven't really been able to incorporate it into their workflow. But I would say the majority of providers and patients have kind of turned that corner, like you said, and we're on the other side of things. All right, so I know we have some questions. So let me go to the questions real quick, Dylan. I didn't see any hands raised. Okay, hang on. Okay, I'm sorry. Some of these are kind of involved to that Athena question. Someone said they so appreciate the prepayment audit. I said, this is a good question. So now that the incentive program is coming to an end, what are your thoughts on the impact of future EHR certifications? So just kind of as in context, as the program has progressed, the certification level for these systems to be able to attest to the incentive program, changed. And so we're currently operating under 2015 certified systems. So do you think that will continue, or have you heard?
Yeah, I can't say for sure, but I think it will. There's still way too much activity going on at the Office of the National Coordinator, and that's where I'm hoping maybe they do some of these things that, that providers really need. And I think what will help is, the EHR program has always driven how providers use their EHR system. But when it goes away, people will start using it what makes them more efficient. They're going to use what they want and not use what they don't see any value in. And I think that's really going to bring a lot of things to the surface that, like, these are the real advantages of using an EHR system. And maybe this stuff isn't quite as important as we thought. But I do think the certification criteria is going to change. These systems need to be more efficient at being able to do stage 3 stuff. The provider shouldn't have to go through 10 different steps to find the provider that they're trying to send a summary of care to. That should be built into that system. If it's certified, it should be able to do that. And I think that they'll continue to build on it. But I think, like you mentioned earlier in the webinar, that it always kind of seemed like the cart was a little bit ahead of the horse, and I think that's not bad mouthing the people that wrote the legislation. None of this, they predicted this stuff 10 years ago. I mean, to try to pinpoint where we would be right now is very difficult, but it always kind of felt like by the time you get providers up to speed on, all right, what you need to be doing, here's how you need to use your system, it's changing to the next stage, and then they're chasing that, and I think that when they look at certification in the future, they really need to look at what providers are asking for, which is an easy way to communicate with the provider that they're referring people to. And I think that there's a way to do that. And, I hope that when they continue to look at these certified systems, that maybe the next generation of them have that in, because that's the biggest thing that we get right now is like, I'm trying to do HIE, but I cannot connect to anybody. It's my system doesn't have a good address book. I can't find an address book at the state level or the national level. And, that technically can be done. And I think maybe it's been overcomplicated in the past, but I think that's something that future certification probably should, and I think will look at.
And in follow-up to that, the question is, we'll use some of the measures from EHR incentive CQMs and behavioral for other P4P, pay for performance programs. Are vendors required to continue to have the measures available in the future for monitoring, or will that end after this incentive program? So I guess the certification program as a whole is not going away. It's just going to be.
And there's a lot of overlap, and if you look at the Medicaid, part of the agency, the way that Medicaid payments are made now through managed care, they're looking at quality data. That's determining how you're getting paid. So I think you're still going to use these systems, after the EHR program is over, and that, it's probably going to involve, how clinical quality data is captured and sent in and things like that. So I don't think anything is going to completely go away, but I think it won't be surrounded by meaningful use requirements. It'll be like, I'm in Florida, I'm a Florida provider, like I have to do this with my EHR system. And that may be, Kim, where when we look into like future webinars that we can do, maybe we could, get someone for Medicaid quality, to kind of talk through what they're doing and how they're trying to make it easier, for providers reporting some of these things that are required for managed care and other programs.
Okay. All right, so that was really all of our questions. Let me take another. Let's see. All right, so let's go. I think we just, so one is, if y'all like this format, if you think this is a good way of communicating information, let us know. Like I said, program requirements have not really changed from 2019 to 2020 to 2021. So we hate to kind of just keep repeating the same information and going over the same measures. So again, looking for different topics and different ways of presenting information that gives you what you need to know, but also kind of keeps you engaged and gives you a sense of what may be happening in the future with a lot of this. So to that end, oh, Dylan, I had a whole slide for you. Sorry. So here's some of our upcoming events. Well, everybody knows who you are. So we do have a upcoming webinar with our HIE counterparts. There's funding available through the HIE program for primary care providers to access information. So we want to make sure that you have that information available. That webinar is going to be on Thursday, February the 11th. I think, I can't see that. And then the other thing that we're starting again in conjunction with our HIE partners is a kind of a series of webinars called Health IT Matters. And it's just going to be kind of presentations much like this with experts from various entities and organizations talking about things that are health IT related. Our first one is going to be with the Department of Health, talking about some of the programs that they've been doing, not only directly with the EHR incentive program, but also with Health Information Exchange and other programs as well. Those are going to be the third Thursday of each month. We'll be pushing out the information to register those. It's also available on our website. So again, just different topics. If you have a topic of something that you would like someone to come, like Dylan was talking about the Medicaid quality people, let us know, and we'll be glad to get something arranged for that.
Yeah, and I think, Kim, me and you have talked that, once we get a little bit further into 2021, of course, we'll have some webinars about 2021 applications and requirements. But I think, over the summer and near the end of the year, we'll do some sort of outside of the box webinars where maybe we have some of our groups that have used their EHR systems and what they're planning to do beyond the program. I think where they see value. I think that always helps for groups and providers to share that information. And then, maybe have some guest speakers that are looking at this from a different perspective and what they see and what they're hearing about. I think that would be beneficial, for people to hear, because that is the biggest question is what's beyond 2021. Even CMS is talking about that. So, so we're going to continue to do webinars, as long as we're around to try to get information out there about not only our program, but other programs that providers may be able to tap into.
Right, and it will be interesting. There's a new administration, day one, day two. So, they may have some really good ideas and good programs planned that they've just not released information about. So we'll just have to wait and see. If you don't already know, there is the Medicaid HIT inbox email address, as well as our website. We are continually updating our website with any kind of learning opportunities. We are working on updated FAQs to address Program 2021 requirements, and then just kind of push out a lot of different resources that will help you through the attestation process. I do know that there have been some questions. I'll funnel those on to Dylan. They're more kind of informational, Dylan, for processing tips with different vendors and that sort of thing, so you can pass it on to your staff as well. And again, if you like this format, let us know. If you want to be a guest speaker, that would be great. And if not, I do not see any more questions. Let me just look one more time. Okay, great. But don't hesitate to reach out, and we look forward to talking with you on February the 11th. Thank you. Oh, wait, Dylan, any final words? Any final words of wisdom?
I don't know about words of wisdom, but I will reiterate that it's a pleasure working with you all. This is a challenging program, and we don't always share good news. And sometimes we vent together, sometimes we share success stories together. Sometimes we have to just say, look, we haven't met the requirements, and what can we do going forward? But everyone has always been, a pleasure to work with, and understanding of the situation that we're in. We're kind of in the middle of the CMS legislation in the provider world, but we're very lucky in Florida to have such great people to work with, and I can't say that enough.
Well, one thing that I hear consistently is that ACA is accessible, and they don't always get that with other payers and insurance companies, and that that people, the processing staff especially, they want to pay these claims, they want to pay these applications, and so they really do appreciate that willingness to work with them. So good job.
And I also have to recognize the processors. I mean, I'm sure there's a lot of providers on here too that would say that they do an outstanding job, and they make my job easy because they're so knowledgeable on the program requirements, and they really turn things around and are accessible to providers. So they do a great job of what they do. So we're lucky to have them as well.
It's a great team effort. Well, thanks again, everyone. You know how to get in touch with us. And if not, we'll talk to you on February the 11th. Take care.
I hope that today's discussion on health IT has given you an idea of what is happening in Florida when it comes to enhancing the technological tools that are available to providers and patients for administering and receiving health care. The Agency for Healthcare Administration continues to promote and pursue these tools to enhance its mission of better healthcare for all Floridians. In our next episode, we will be sitting down with Michael Craig, the HMS Project Manager at the Department of Health, to learn about health IT initiatives the Department of Health is utilizing to improve public health. You can stay up to date with podcast episodes and all other agency-related news through our social media pages on Twitter at ACA_Florida, on Facebook at Florida Agency for Healthcare Administration, and LinkedIn. Until next time, this is Corinne Slaughterback for Health IT Matters. Thank you for joining us.